I'm Kate Walker, the Senior Methodologist for the Non-Hodgkin Lymphoma Audit, and presenting on behalf of Ruhi Kanani, who's our clinical fellow, and she's gone off to have a baby. Next slide, please. So starting with diagnosis and staging part of the pathway, we had 15,433 patients diagnosed in 2022 with non-Hodgkin lymphoma in England and 729 diagnosed in Wales in 2023. They're the most recent years of data from gold standard cancer registry data available to us. For the first time this year, we've looked at the patients presenting in an emergency for non-Hodgkin lymphoma and found that this in England is 28% overall, with variation between trusts. Between 23 and 33% was the interquartile range for England. We are working to develop this indicator for Wales as well. And as a result of this, we made our first recommendation in our State of the Nation report that emergency presentations should be reduced, for example, by examining variation in rates of emergency presentation by geographies and by population groups to identify potential causes. There's a lot more work we need to do, I think, in the audit to try and understand what exactly is going on for which groups there. And then within the hospitals to review diagnostic pathways into and within secondary care to improve timely investigation. Next slide, please. So staying with diagnosis and staging, we report on the proportion of patients who saw a clinical nurse specialist. We do have an issue with data completeness here. So you can see that for England, only 40% of patients have this recorded at all. And within those, 83% within England were recorded as seeing a clinical nurse specialist. That was 96% for Wales. So clearly some data issues to work through there. Our indicator on MDT discussion within 4 weeks of diagnosis. Again, some issues with data completeness there, but not as bad, 72% data completeness for England. And what we're seeing is that 60% of patients in England were recorded as being discussed at MDT within 4 weeks, where that information has been recorded to us. We don't have that recorded in Wales. And we do see quite wide variation between trusts in England, with an interquartile range of between 51 and 72%. Next slide, please. Moving now on to treatment, we have a metric about the proportion of patients who start SACT within 62 days of referral. This is amongst patients with high-grade lymphoma. And you can see there that in England, only 55% of them are starting their SACT within 62 days. And for Wales, that's 48%. Again, wide variation between trusts, MDTs. We've got interquartile range of between 45 and 64% for England, between 35 and 56% for Wales. So this formed the second of our recommendations in our State of the Nation report, that there should be local review to identify delays and reduce variation between providers in this waiting time. This may include examination of delays along the diagnostic and treatment pathway, chemotherapy unit capacity and staffing, as well as mode of delivery of SACT. And I think that the audit does need to do more work to understand exactly where in the pathway these delays are occurring and in which particular groups of patients. Next slide, please. So this is about timing of radiotherapy following completion of first-line SACT. And our indicators that the radiotherapy should start within 8 weeks at the end of first-line SACT. We don't have this measure in Wales because we don't have the end date for the chemotherapy there. But in England, we found that of those having radiotherapy after SACT, 33% of them started within 8 weeks. Again, wide variation between providers, between 11% and 50% as the interquartile range there. Next, please. This is our third recommendation. So we identify, we recommend that patient and hospital factors are identified that are contributing to these delays. We recommend exploring strategies to reduce variation across providers, which may include ensuring specialist representation at MDT meetings, earlier identification of appropriate candidates for radiotherapy, a review of radiotherapy unit capacity and staffing. Next slide, please. We have a new indicator this year's State of the Nation report on trial participation. From what we've been able to estimate so far, using the cancer waiting times data, we only have a record of 2% of patients with non-Hodgkin lymphoma who are recorded as having received any care as part of a clinical trial in England in 2022. Note that we do have issues with data quality here. Also, the audit does plan to do some more development work to see if we can get that information from other sources as well and triangulate that information. But we already do recommend that providers identify reasons why patients were not enrolled in trials to ensure equitable access. And we're also asking for improved record keeping of that enrolment in trials so that we can better audit that metric. Next slide, please. So on to the survival now of the pathway. We reported by subtype the 1 year and 2 year survival for England and 1 year survival for Wales. And this is our start of our outlier reporting in the non-Hodgkin lymphoma audit. So risk-adjusted 1 year and 2 year survival has gone through the outlier process for the first time. We adjust for age, sex, stage, subtype, performance status, comorbidities, diagnosis route, diagnosis year, and obviously that relies on accurate risk factor measurement. So we really need improved data quality to be able to accurately risk adjust these. But the next point, please, on the slide, we did identify one positive outlier, so someone with higher than expected survival on 1 year risk adjusted survival. We did not identify so far any negative outliers, but as I say, we do need to be careful with our risk adjustment. Next slide, please. So this moves on to our final recommendation, which I keep mentioning, the issue we are really encountering with this audit in particular, I would say, partly because it's a new audit, and I think also because of the issues particular to hematological cancers, we are having issues with data completeness. And you can see there, for example, that the staging information particularly does need improving. Next point, please. The recommendation, final one in our State of the Nation report, was to ensure that there is a designated coordinator or clinician in each MDT to improve completeness here, with a particular focus on staging in both England and Wales, and for example, treatment delivery in Wales. And as I say, as well as understanding variation in care and outcomes, it's also crucial to allow better risk adjustment and allow us to effectively outlier report. Next slide, please. This brings me on to the focus of our quality improvement intervention. We are focusing on improving data quality, because without that, we won't be able to accurately report about non-Hodgkin lymphoma care and improve care and outcomes for patients. The intervention has launched already. We had a webinar last week, and we have materials coming up on our website there will be the recording of our webinar, case studies of how improvements have been made in some trusts. So The intervention itself, as well as having our webinar, is a targeted feedback intervention with bespoke feedback being sent to any trusts in England with less than 50% completeness on Ann Arbor staging. England, because that's where we have our quarterly data dashboards, which can support the work. Please go to the NACAM website, find this link to the data dashboards. Next slide, please. And you can see here that there is a really wide variation between providers, with some trusts managing to have excellent data completeness on Ann Arbor staging, even in the most recent data. And there's a lot we can learn from that, which we showed in our webinar last week. And we're really working to get the trusts at the right-hand end of that rank to our chart shifted over to the left. We think there's real potential there. We can make some improvement. Final slide, please. Thank you to everyone in the non-Hodgkin lymphoma audit team, their pictures there, and especially thanks to our partners and chairs of our clinical reference group and our patient and public involvement forum. Thanks very much.